to your seats. I want to welcome you all here for our last week of school. We have a very special class today. We have interprofessional colleagues from 5 continents that are joining us for our class. Okay, to talk about the healthcare experience in their country. And one of the things that we ask is that you give them your utmost attention. You also be ready to ask questions. We'll have a kind of a break in the middle where you can ask questions. I would hope you'd be able to ask some questions, especially if someone is presenting on a country that you are doing your global health report on. You have a great source here. So we have the first person I want to introduce you to is we can turn on the recording. You did, okay. We can turn on the, what was it say? I would like to introduce you to Allison Power. Allison, last spring, hello everyone. Okay, thank you. Last spring, spent a semester helping teach this class from the University of Northampton in England. And she actually came and did this global panel in person here. She taught in this room. And she also participated quite a bit. She's a very, very good colleague of mine. And like I said, the 7 other colleagues that will be presenting today represent 5 different continents. All of them are colleagues that I work with in Interprofessional.global, and they were very generous with their time to be able to come and share their perspectives on their healthcare systems in their country. Because it's one thing to write a report about it, it's another thing to actually live it. And so we have the bios for all of these people on a doc that's in Canvas. So if you want to learn more about them as people, they are going to introduce themselves a little bit. So what I'm going to do is I'm going to stop share and I'm going to turn it over to Allison because she's going to serve as our moderator. Okay, stop share. There we go. Do you want to spotlight Allison? There we go.
Oh, I'm on the spotlight. Hi, thank you, Dr. Brightback. Yeah, it was my absolute pleasure last year to be with you in person. I'm really quite sad I'm just on the TV screen today, but I'm delighted to still be in touch. And I am in the presence of giants in the field of IPE with my very esteemed colleagues that you see on the screen. We are so lucky to have them and to learn from them this evening. Every time I speak to them, I learn something, so you're in for a treat tonight. Academics who are into IPE are very passionate about it, and it's very difficult to keep them in line and keep them to time once they start talking. I've actually got my timer with me tonight, so I will be timing everybody just to make sure that we can hear from all of the different continents and give everybody their time to shine and their time to speak to the class today. So the way we're going to run things this evening is I'm going to ask each of our panel members in turn, initially 2 questions, and they'll get 6 minutes each, no less, no more. And then we'll go around again and ask them a final question. And we hope to give you enough time at the end to have a really good opportunity to ask some more in-depth questions that may well help you with your assignment at the end of this semester. So that's how things are going to play out. So I'm just going to go to the panel as I see them on my screen, if that's okay. And panel members, I'll turn my camera off while you're talking. When the camera goes back on, it means you've got 30 seconds. That's how I'm going to do it today. So when you see me come back, that's because you need to start wrapping it up if at all possible. So the first person on my screen is Jan Jaap Reinders. So I will be asking everybody in turn the following 2 questions, and you'll have 6 minutes each. So firstly, could you please describe how healthcare is structured in your country, so obviously the Netherlands for Jan Jaap, and then tell us a bit about what you think is good about it and what are the challenges that you currently face in the Netherlands. So over to you, Jan Jaap.
Yeah,
How-
thank
yeah,
you. Thank you very much for the introduction. Yeah, I'm from the Netherlands, and my name is Jan Jaap Reinders, as you heard. With regard to the healthcare system in the Netherlands, we have mandatory insurance. So all Dutch must have an insurance, but there's a kind of a limit also of your personal expenses. So that's how the Dutch healthcare is arranged. We have a lot of regulated care, government regulation, very strict. And we have an emphasis also on primary healthcare, where the GP, the general practitioner, is perceived as the gatekeeper to prevent a bottleneck to the secondary care in the Netherlands. So they have a very important role. Downside is that we have we have a lack of GPs, especially also in the north and the east of the Netherlands. So that's the downside. It is in practice, it is a beautiful idea. The healthcare as it is organized in the Netherlands with the GPs as a gatekeeper, but we do face some challenges, but of course I will tell a bit more about that. There is some additional funding depending on what kind of patient category. So there are different kinds of funding, a hybrid system also in the Netherlands. So the strength of Dutch healthcare is a very high quality. There's just if you compare, for instance, surgical equipment, and you compare them with many other countries. Like I've been talking to a Dutch surgeon the other day, and he told me that he when he goes abroad, he's always interested in how many ways you can have sutures when you operate. So how many sutures are there? So in some countries there are like I've been told by him like 5 or maybe 10 options. In the Netherlands, it can be up to I believe to 60 or even 70 options for operation. So that he says, this is a surgeon who says that it's for him that's the amount of possibilities on how to operate is also an indication of the quality of care. Of course, it's not only about surgery; it's also about other indications that it is a very high quality of care. A lot of technology, high technology. We have, as I told before, there's also quality universal access. We have not as many hospitals as in, for instance, Switzerland. They have many more. We have about 78 hospitals in the Netherlands, and 8 hospitals are university medical centers. The largest one is University Medical Center Groningen. It's about 13,000, more than 13,000 staff members, and there's really they have kind of a centralized function within those different regions within the Netherlands, and it works quite well. They have more specialized care within those hospitals, and less specialized care are in what we call peripheral hospitals. There's also a lot of cost efficient care. So this is really important. I think that's also very good quality, good strength of Dutch healthcare. With regard to the challenges, I think there's a lot of similarities with other countries. For instance, we have an aging population. Mostly mostly even up north, but also in the south of the Netherlands. This also poses more problems because proportionally there are some regions where there are more older people than young people to take care of them. So there is really one of the ways to tackle this is by introducing other ways of working. And of course, interprofessional collaboration becomes, for this reason, more important in the Netherlands. There are many projects that are focused on interprofessional collaboration, and also more recently in the past years, primary care becomes also more of a focus of interprofessional learning and working. So we also have a lot of workforce shortages besides an aging population. And the aging population is not just only due to people just getting older. We also have demographic differences within our country because of the Second World War, where there is what we call them baby boomers. So we call that double gray in Dutch, double gray. And work shortages are also related to our demographics. There's shortages everywhere and not just in healthcare. And we have, with regard to healthcare, we have some difficulties with complexity. So there can be a lot of bureaucracy in the Netherlands. That's the downside. That's a challenge. Also, understandable insurance policies is also a very difficult thing in the Netherlands. So a lot of people, quite often, they don't bother changing insurances. Each year you can. There's a certain window of opportunity to change between insurance companies, but because of a lack of transparency, this also is very difficult for many Dutch people, especially those with less education, even though many people in the Netherlands are quite highly educated. So the challenges, besides interprofessional learning and working to overcome this change in this population, you see people getting older. So we have also more people with comorbidity or polypharmacy, which poses incredible problems. Many projects are also related to technology, the use of technology for improved information exchange. At the same time, we also have difficulties with information exchange to make it a more fluid, organized process, which is also a bit difficult because of privacy law is very strict in the Netherlands. So these are the most important challenges I think I can imagine. Also, the current issues we have to solve this. We have new policies introduced to overcome these challenges, like on a national level, the National Dutch Federation of University Medical Centers now introduce or are working a new policy to have more interprofessional learning and working within the hospital setting in the secondary care.
Yeah, I think Allison's trying to get your attention.
I thought, okay. Oh, yes, yeah, sorry.
Do you think I was just waiting?
That's the 6 minutes.
You see, I'm too polite for this. I'm smiling, I'm waving, I'm putting my hand up, but you're just on a roll. Because you got into your groove. It was brilliant. Thank you. So I won't be so polite with everybody else, because otherwise Tony will come in and say it. But thank you so much, Janja. For now, I will come back to you with question 2 on the next round. Thank you so much. So next person on my screen is John. John, if you're happy to do the same thing, please. Do you need the question repeated, John?
No, that's fine.
Perfect.
Well, good morning and a welcome from Vancouver, Canada. I'm joining you from the traditional ancestral unceded territory of the Musqueam peoples. And it's a great pleasure to be here again to talk with you about the Canadian healthcare system. Canada's healthcare system, which is known as Medicare, is a publicly funded universal system that provides all citizens and permanent residents with access to medically necessary hospital and physician services without direct charges at the point of care. And in Canada, healthcare is a right, not a privilege. The system is a defining feature of Canada's identity, and it's often cited as one of the best in the world. There might be some discussion about that, but of course, we also have our challenges and debates about its future. Now, healthcare in Canada is administered primarily by the 10 provinces and 3 territories, and each of them operates its own insurance plan. The population of Canada is approximately 40 million people. And so the variation is from territory to territory and province to province in terms of population. And so while the federal government sets and enforces national standards through the Canada Health Act, just Google it, you can find it, the provinces and territories are responsible for organizing and delivering service. It comes all the way down to the provinces, all the way down to the territories to deliver the service. And to receive full federal funding, each provincial plan has to adhere to 5 principles. It has to be public administration, nonprofit management. It has to be comprehensive, coverage of all medically necessary services. Universality, all residents are covered regardless. And portability, doesn't matter where you go in the country, whatever province you're in, you will get covered. And accessibility, access without any financial barrier. The system itself is funded through taxes at both the federal level and at the provincial and territorial levels. The federal government, which is in Ottawa, Ontario, contributes via the Canadian Health Transfer Arrangement with the provinces, but most funding comes from provinces and territories themselves. Now, medically necessary hospital and physician services are universally covered and free at the point of contact. And so that includes emergency care, surgeries, diagnostic tests, etc. But not all health needs are covered. So outpatient prescription drugs, dental care, vision care, mental health services, physiotherapy, home care, they're often excluded or only partially covered. So about 2/3 of Canadians have a kind of private insurance plan, although frequently employers help to pay for those services. And because provinces define medically necessary and manage their own plans, there are some differences in coverage, especially for services like mental health, because some provinces will say, we want to spend more on mental health than on acute care. So that's a provincial prerogative. Fertility treatments, it depends which province you go to, and then gender affirming care. The strength of the system is that, as I've said, all Canadian residents have access to essential healthcare services, regardless of income or employment status. It's really, really important to remember that. The system is designed to provide care based on need, not on ability to pay, and access is not affected by job loss or pre-existing conditions. It doesn't matter what condition you're in, whether you're poor, etc., you still are covered by the system. You can, as I said, you can access the care anywhere in the country, and coverage is maintained when you move between province or territories. The system is structured to provide timely care for emergencies like heart attacks or accidents, and we have a medevac service for those who live in rural, remote communities. I'll talk about challenges and so on later on, but we are always in the process of reform. We are actively working on expanding access to family docs, especially in underserved areas, and building healthcare teams which are truly interprofessional. The province of Ontario is putting millions and millions of dollars into developing healthcare teams which are truly interprofessional. It's a very interesting act, and the same thing is beginning to happen in my province of British Columbia. We have a big presence here through UBC Health of Interprofessional Education Collaborative Practice. We put a lot of time in looking at quality of care and services, bearing in mind safety aspects. So we're trying to reduce surgical diagnostic backlogs, as everybody is. And then, of course, with AI, working like mad to modernize healthcare information systems with digital records. Not as good as we would like to be. The electronic health record has been hugely fought over, very, very expensive. And I'm not sure that we're ever going to get there for the entire country. But provinces have their own systems, but maybe AI will solve this problem for us. I don't know, but that's it. So it's a source of great pride. It is universal, but like every other system, we're working on changes. Thank you for your attention, all my relations.
That was perfectly timed. Thank you so much, John. Thank you. We're back on track now, Yanya. And now if we could please go to Marion. Thank you so much, John.
Yeah, hi everyone. I'm from Switzerland. And Yanya, and also John said something we all have. So we have really a mixture of all existing systems all over the world. We have a lot of hospitals. So I just looked in ChatGPT how much we have, because I didn't know that. 100 general hospitals, 52 psychiatric clinics, and 51 rehabilitation clinics, and 74 other specialized clinics. And all these clinics, it's a lot of, for around about 8 million inhabitants in Switzerland. So we are a very small country. We are not Sweden, we are Switzerland. Don't, sorry, because a lot of people are thinking that we are Sweden, we are Switzerland, in between Germany, France, Austria, and Italy. Our funding system, or the paying system of the insurance. So we have also a mandatory insurance system, which covers more or less the basic health care. We have a lot of additional possibilities for extra insurances, and but I think the most healthcare we need is covered by the basic insurance. Psychotherapy, as an example, isn't included in that, and also not dental care. Dental care we have to do an own insurance. But it has a federal structure, our healthcare system. The responsibilities, and this is one of the challenges, is divided among the federal, the cantonal, and the municipal levels. So nobody knows really exactly who is paying for what. And that's really one of the challenges, because mostly the money is somewhere. Nobody knows exactly where it is at the moment and who is responsible for paying for special care. The cantons, Switzerland has 26 cantons, so sub-states or little areas. They are very autonomous in doing the rules, who is paying for what. If our people or our financial system for the insurance, we have to pay on our own. So not the employee doesn't pay anything at the healthcare costs. And we have also something like a fee. So we have to pay our insurance, and then we have to pay at minimum on ourselves the cost for the healthcare per year. The minimum is 300 Swiss francs. The maximum is 2,500 Swiss francs. It's not a fair system. If I'm earning a lot of, for me, health insurance and healthcare is very cheap. If I'm earning less, or if I'm low income, healthcare in Switzerland is very expensive, because we all have to pay this extra fee. If somebody can't afford the insurance, the state, the governance will fund it. So then it's a social system, but only then. In all other cases, it's not a fair system. Also, one of the challenges is that we have a highly specialized medicine, especially. So the hospitals are highly specialized, and the specialization is really something which works again interprofessional collaboration. And it is a topic. We have a lot of different projects, mostly from the universities, mostly from the University of Applied Sciences, to cover some needs of the community of the communities. But at the end, interprofessional collaboration is in the specialized hospitalization. It's not a really big topic. So yeah, I think that's something important. Yeah. And the challenge, I think the biggest challenge is the unfair system we have. So I would be.
Marion, thank you so much. I now have James next on my screen. If you'd like to share your experiences of Australia, James, that'd be fantastic. Thank you, Marion.
Thanks, Alison, and good morning to you. I'm currently based in Broome, in northern Western Australia, right up at the top of the country. To understand the Australian healthcare system, you've got to understand a little bit about the context first. So Australia's this huge country, about the same landmass as the continental United States, but with a much smaller population. We have a population of about 26 million people compared to the US, over 330 million. The other unique aspect is that our population distribution is unique. About 90% of Australians live within 100 kilometres of the coast, mostly concentrated in the state capital cities, Sydney, Melbourne, Perth, for instance. Rural Australia, sometimes referred to as the outback, is this vast, remote, and often kind of harsh landscape that covers most of the rest of the country. Imagine it like combining the isolation of rural Alaska, the heat of the New Mexico desert, and the emptiness of the Great Plains, but on an even bigger scale. The second thing to understand about Australian context is this incredible ancient human history that we have here. Aboriginal peoples have lived on the continent for over 60,000 years, making it one of the world's oldest continuous cultures. In the 18th century, the British arrived and colonized Australia, and then Australia became its own independent nation in 1901, but it still has these close political, cultural, and institutional ties to Great Britain. And the reconciliation process between the sort of colonial age with Indigenous cultures is a really important aspect of Australian society at the moment. So Australia's healthcare system is a mixed public-private system. From a public perspective, it's similar to Canada in that we have Medicare, which is a public universal health insurance scheme, which is funded through taxation. Under Medicare in Australia, public hospital care is free for all Australian and Australian residents, and access to primary care, such as visiting your GP, is heavily subsidised. Australia also operates a pharmaceutical benefits scheme, or PBS. This subsidises medications and makes essential medicines affordable for all Australians. This public system is supplemented by private health insurance, which plays a significant role. This system, which many people buy into, offers faster access to elective procedures and a greater choice of hospital and doctors and other healthcare providers. Again, similar to Canada, state and territory governments manage public health services, but the federal government funds these health services. So look, what's good about the Australian health system? Firstly, universal access. All Australians have access to essential healthcare, regardless of their income. Secondly, the quality of care in Australia is very high, consistently ranks highly at a global level on all measures such as life expectancy and other healthcare outcomes. This, I think, is underpinned by an outstanding health education system that we have here in Australia. Thirdly, we've got very strong primary care here in Australia. The GP system ensures appropriate referrals to specialists. The GP system ensures good preventative and chronic disease management. And there's lots of allied health services that are available as first contact. So people don't need a referral to access many allied health services. But look, we've got many challenges in Australia with our healthcare system. I'll just draw your attention to two that I think are particularly interesting for our context. One is rural and remote healthcare access, and the second one is the issue of health inequalities for Indigenous Australians. In terms of rural healthcare, about a quarter of the Australian population, 7 million people, live rurally. And whilst Australians contribute significantly to the wealth of the country, there's a huge health spend shortfall between urban and rural Australians to the tune of about 6.5 billion Australian dollars a year. And as a result of this and some other logistical issues, rural Australians experience significant health disparities compared to their urban counterparts. To give an example, I'm up here in Broome. The nearest state capital to where I'm based is in Perth. This is over 2,000 kilometres away. So imagine the distance between New York City and Miami, and there's literally nothing in between Broome and Perth. So whilst that's extreme, rural Australia is characterised by this small and dispersed population. So traditional urban healthcare models are often unviable in rural Australia. This is resolved in a number of ways. Telehealth, I think, has always been a big aspect of Australian rural healthcare. The other thing that we use a lot here is aircraft. So we fly specialists in to our rural towns to run clinics and do surgery, for instance. The state government has a funding service where patients can travel to their nearest centre to receive healthcare if that's needed. And we also have the Royal Flying Doctor Service, which is known globally, which operates emergency care and preventative care around rural Australia. The second challenge I'll just draw your attention to is the Indigenous health inequalities that exist in Australia. So look, despite having lived here for 60,000 years, Indigenous Australians have faced widespread displacement and discrimination since colonisation, and the impacts of this historical trauma continue to affect health behaviours, service access, and general trust in a non-Indigenous healthcare system. As a result of this and a few other issues, Indigenous Australians continue to experience poorer health outcomes than non-Indigenous Australians, with significantly shorter life expectancy and higher rates of chronic illness, mental health conditions, and other preventable diseases. So one of the things that we focus on is this idea of culturally safe healthcare. This is not just making healthcare available to Indigenous Australians, but also delivering it in a way that is respectful of Indigenous worldviews and Indigenous cultures. I'll give you an example. Throughout Australia, we have Aboriginal community-controlled health services. These are publicly funded health services which are owned and operated by Indigenous communities, and they're built on this idea of self-determination. So healthcare is being delivered to Indigenous Australians by Indigenous Australians in a way that is culturally appropriate for those people. So this is just part of this national movement that Australia is currently partway through around reconciliation. And it's about just sort of building respectful relationships between Indigenous and non-Indigenous people. Look, it's complex, but it's an important part of improving Australian healthcare and Australian society overall. Anyway, thanks for listening. Thanks. Back to you, Alison.
Thank you so much, James. That was great. Now we go to Vicky.
Hi, everybody. So I'm joining you on a lovely spring evening from the northeast of England, from Newcastle. So it's an absolute pleasure to join you this evening and tell you a little bit about the healthcare and social care service that we have here in the United Kingdom. So I think probably the best way to start is just to give a global overview of the types of health and social care services that are provided across the United Kingdom. So we have primary care, which would be doctors, general practitioners. We have secondary care, which would be things like hospital. We also have social care, which is provided by local authorities. And there's reliance also on the voluntary and charitable sector as well to help us to provide care. But the largest provider of care in the UK is the National Health Service, so that's the NHS, which was actually launched in 1948, and we follow the Bevan model of care. I can see John nodding because Canada is very much also based on that model. So in terms of that provision, I think what people may not potentially realise is we've actually got a private sector. We do rely on the voluntary and charitable sector. There's lots of other types of service provision. It's not just the NHS, but the NHS is certainly the largest. So in terms of context, I think what's really important to understand, because I'm with James on this, context is everything. So in terms of context, I think what's really interesting to understand is how the United Kingdom is actually structured. So we have 4 nations in the United Kingdom, and overall we have a population of around about 68 million people. We might look tiny on the map, but there's an awful lot of people squeezed into those 4 nations. So we have about 57.5 million people in England, about 5.5 in Scotland, 3 in Wales, and nearly 2 in Northern Ireland. So there's quite a lot of people in quite a small amount of space there on our lovely islands. And the reason this is important when we talk about 68 million people is because actually that requires an awful lot of funding. So the majority of funding for the people who are accessing care is from the government, and that's largely generated through taxation, through national insurance contributions, and about 1% of that comes from fees, such as the likes, as John was alluding to, eye care may carry a charge, for example. For some people, they have to pay dental care. So there are about 1% of funds are generated for the NHS, and they actually come through those charges that some people may pay. Eye-watering amounts of money are spent on an annual basis. The most recent data I was able to obtain was that £188 billion was spent last year alone just on NHS care provision. And as the 5th biggest employer in the world, it employs about 1.7 million people. So this is a really, really large organisation for an awful lot of people. And there are about 2 million attendances every year, for example, to accident and emergency. So it starts to give you a little bit of an idea as to how heavily utilised the services are and how many people are accessing them. 37% of the National Health Service workforce is made up of nurses and doctors. So we do have a multidisciplinary workforce, which means that the remaining amount are from other professions. Now, the reason I'm sharing all of this data with you is because the next point to raise is a bit of a double-edged sword. And what I mean by that is we also have a growing population. So the NHS, to an extent, is a victim of its own success. So through the NHS being introduced, we've improved the quality of lives. We have a growing population. We have overall more births than deaths. And we are genuinely a success story in terms of how the NHS has actually provided care for the population over time. The flip side of that, which is when one of the challenges starts to come into play, is what this actually means for us is we have an ageing population. So 19% of people are over the age of 65, according to the most recent data. So that's about 12.5 million people in the United Kingdom. It's about 1/5 of the population are over the age of 65. That's estimated to reach almost 30% by 2072. So that is a large amount of our population who are considered to be older. And because we're doing such a sterling job at actually prolonging people's lives and improving the quality of life, that additionally means that the people accessing services are likely to accumulate additional conditions, more comorbidities, and the complexity of care actually increases the longer a person lives. So 1 in 17 of all workers in England work for the NHS. And where we're at the moment in the UK is we additionally have workforce shortages. And what's actually needed is for those numbers to increase quite dramatically. Now, in terms of the strengths, I think, that we have, the NHS is founded on principles of equity, on accessibility, on being free to the point of service. It is mostly free to people, and we have lots of plans in place to try and improve the workforce. I think what's interesting when a group of us come together like this is to look at what we all have in common. We all have shortages. We all have increasing complexity of care. We all have problems with financial flow, shall we say. It's very expensive to have care. We're all having great fun trying to get technology embedded to improve the quality of care that we're given. And we're all desperately trying to work together to make sure that people receive the best care possible and that that care is holistic. So I think what I'd like to just end on is a few of the more recent challenges that have probably happened in the last 12 months. And to give a nod to that, we've got a cost of living crisis in the United Kingdom. This is causing all sorts of problems for us across here. We are currently experiencing what's been termed an HE, higher education crisis. So we have a financial crisis across the higher education sector where lots of professions are losing their jobs across here. And that has now reached into the health and social care workforce as well, where, for example, our integrated care systems have been told they've got to save 50% of funding. National Health Service England is being abolished in the next 2 years. We're losing 9,000 jobs over the next 2 years as that's been resumed in the Department of Health and Social Care. And a lot of this is coming with the backdrop of a new government who are bringing in new plans and who are driving things forward. So I think to summarise the strengths, we live on the legacy of the NHS. We're very proud for the principles that the NHS have. We are fiercely protective of the principles of the NHS because care should be free to all. But the challenges that we face are global, local and regional and very real. And I would say the biggest challenges that we have ultimately come down to finances and people. Thanks, Alison.
Thank you, Vicky. Thanks so much, my love. And Luzanne, would you like to go next? Thank you for being so patient, people, this end of the queue. But we'd love to hear about healthcare in South Africa, Luzanne. Thank you. Thanks, Vicky.
Thank you, Alison. I'm freaking out a little bit with the panel that's here tonight. I was actually just sending everyone messages to brag a little about the panel that I'm speaking with tonight. But I'm Luzanne Africa. I'm a lecturer in the Interprofessional Education Unit at the University of the Western Cape in South Africa. So that's a lot of use of the word Africa in that one sentence, but I'm also from the Africa Interprofessional Education Network, which is AfriPen. So I think what makes today so particularly special for me is the fact that today is Freedom Day observed, because the 27th, which was yesterday, fell on a Sunday. We had the day off today. And I'm saying had because it's past 9 p.m. already. But on the 27th of April, 1994, South Africa held its first democratic elections where all the citizens of our country could vote for the first time. So this was actually the official end to the apartheid era. And so sharing a bit about our health system, which I think I know a bit more of than politics, but makes it particularly special today. So I'm sharing today not just as a health professional from South Africa, but also as someone who has worked and lived as a physiotherapist within that system. And so just for a bit of background, so South Africa uses a dual healthcare system in which we have a public sector that serves the majority of the population and a private sector that serves the smaller, more wealthy or more affluent group. So in theory, we are committed to the idea of universal healthcare. So at the eradication of the apartheid regime, primary healthcare was declared free for all citizens. And so in South Africa, what makes it different to, I know there are political issues across the globe, but in South Africa, what made it particularly more difficult was the fact that the marginalized population, in terms of people numbers, was the majority of the population. And so as a result, after declaring primary healthcare free for all, the public hospitals and clinics were frequently overcrowded, under-resourced. And when we speak about under-resourced, we are referring to human resources, financial resources, infrastructure, the whole lot of it. And obviously the health professionals working in those facilities were stretched beyond capacity, especially, and a few people have mentioned it tonight, especially in the rural areas. And so, as you can imagine, this is a direct weight of the history in South Africa. And the inequalities that was created by apartheid really only started showing through now, now that we're starting to almost take account of who gets access to healthcare and whose lives are affected by the quadruple burden of disease that South Africa faces, and who continues to be left behind. And so at the same time, I mentioned that we have a private sector. And so in this private sector, and a lot of, like I mentioned, it's a wealthier group. So we have a similar system. We call it a medical aid system, which is very similar to the health insurances. So you sign up with whatever company aligns with your work or whatever you can afford. That offers excellent healthcare and a range of services and minimal waiting time. But again, that is only to people who can truly afford it. And oftentimes, even if you are paying your medical aid, the medical aid doesn't cover all the services in the private healthcare sector, because we have health professionals working in that sector that then claim 3-4 times the medical aid rates, which means that your medical aid then doesn't pay out the entire amount. So you then have to fork that out yourself. So despite all of the challenges, we do have some hope. South Africa is leading in a lot of world programs, or in a lot of areas in the world, such as the HIV/AIDS treatment, vaccine development, and community healthcare worker programs that we have in South Africa. And this is actually a very terrible thing to use as a benefit or as something good from our health system, but we have healthcare professionals who are extremely resilient because of the challenges that we face. And so we often find that they have to be creative. We live in a country with 12 official languages. I only speak 2 of it. So you can imagine when I work as a health professional, how I often have to decipher even what the language is the person is speaking about, never mind getting to a point where I can communicate with my patient, to find someone to translate for me. And so I think we are seeing a push towards universal health insurance, which is the new policy that our government is proposing. We are getting, I'm saying we, but the government is getting a lot of pushback from especially the private healthcare sector, because it obviously has impact on their income. But the National Health Insurance looks at merging and pooling all the funds that would usually go to the private sector and grouping them into one, and having this health insurance, national health insurance card, that patients can then access healthcare closest to where they live and work. So just for an example, I live in a community called Curls River, and here is a hospital about 1 kilometer away from my house. And I can access it because I have medical aid. But my neighbor who does not have medical aid has to travel 10 kilometers because that is the closest public healthcare facility to her. So that is an example of why there is this push and this drive towards the NHI. But like I mentioned, there is pushback. And so when we move on to our next question, there are a few ideas that I have that I think we should keep in mind as health professionals on a way forward. Thank you, Alison.
Thank you so much, Lizanne. That was great. And now, last but definitely not least, we have Mike, who is going to talk about healthcare in the Philippines. Thank you, Lizanne.
Thank you all, and thank you, Alison. So I would like to, maybe since I'm the last person, I would like to compare our healthcare system, the Philippines, similar to South Africa and very far from what Switzerland healthcare system is. The Philippines is 115 million people, but it is as big as Italy. And it's a very small country with so many people. And you can imagine that there are just a shortage of healthcare professionals that can manage and provide access to the healthcare of the Filipino people. So I would like to start describing the Philippines, which is an archipelago of more than 7,000 islands. So you can just imagine how many languages and cultures there are in this small island. Yes, it is a tropical destination for most of you, but it is also facing a lot of challenges when it comes to health. First is the dual public-private structure, which means that most of the people can access healthcare from the private sector, although there is free healthcare, but there's also an issue on the quality of care that you can receive. And usually in the public healthcare services, you would need to queue up and wait for long lines to get access to it. But again, like in South Africa, if you have the money and you have the proper insurances, then you can go to a private hospital or clinic and get the services that you want. We also are now, we have a universal healthcare law, but until today, it is still a law, an idea, and isn't implemented at the moment, although it has been approved since 2019, but because of bureaucracies and issues, and like Lausanne, what she said about the pushback of the private sector, there is a slowing down of how universal healthcare, or how the public can receive free healthcare services. That's the idea, but it's still an idea until today. There are a lot of challenges when it comes to accessibility and quality. So we cannot build trains because we are an island country. So we need to think of how people can access hospitals if they are from another island. So usually there are boats that act as ambulance, and it's not always possible for many people to do that. And then, for example, when it comes to quality care, because of the disparity, you can have different kinds of services. It depends on how much you have, which is very unfortunate. Another issue, and the last issue that I'll be discussing in this panel, is the workforce shortages. A strength is that the Filipinos, is known to have highly skilled healthcare professionals around the world. I think I'm very proud of that. But because of opportunities abroad, they migrate, and so we are left with a shortage in the local context, in the local landscape. So, and also we speak, English is an official language in the Philippines, along with the Filipino language. And although it's good to have good English speaking skills, reading and comprehension, it is also a disadvantage because it allows more healthcare professionals to get a job abroad. So that's a disadvantage as well. Some strengths is that we have a very young population. I think we have 30% of our population below 24 years old, which is good for the economy. And I think, like in South Africa, our healthcare workforce is quite resilient because healthcare is not only done in the hospitals, but also in the communities, especially in the middle of disasters, because our country is, I think, one of the top 3 disaster-stricken countries in the world after Japan. And I think disaster is a daily, ordinary part of our lives there. So you have volcanic eruptions, earthquakes, tsunamis, typhoons, and healthcare professionals are a big part of the disaster management teams who are being deployed to save people, literally saving people's lives. So that's one strength of the healthcare workforce. And what else? I already mentioned about the highly skilled healthcare workforce. So yeah, I think I'm done. Alison, please.
Wow.
I want to discuss more, but I should stop now.
I wasn't expecting that. Well done, Mike. You did great. Thank you so much. So it's been fascinating, I think. Tony, were you going to say something there?
Yeah, can I say something for a quick second?
Of course.
So number one, thank you to you all for presenting. We are going to do another round of questions, but this is really, really good information. I ask our class to take a quick break from multitasking. Please shut all your devices for the next round of questions, please. And one thing we would like to open it up to questions. Does anyone have any questions of anyone on the panel right now? Does anyone have any questions about countries or what time it is there or any of those types of things like that? Anybody? Want some bonus points? There we go. Got one.
My name's Emma. I'm team 8, and I was just wondering what everybody's like fields and specialties are, and like what part of healthcare you work in.
Yeah, I think we'll have them say that when we go through the next round of questions. Does that sound good? We'll have everyone say their profession when we go through the next round of questions. Perfect. Thanks. We got one up there.
Is it on? Okay, like this is I'm Sylvia from Team 27. I have a question for the two people from the UK. With the new like ruling regarding trans healthcare, what would you say like how would you say that would like affect like healthcare like in England in general? Sorry. Like from the news I couldn't like really understand if that was from the news that I read about. I couldn't understand if that was like just like a whole UK thing, or if that was just like in England specifically. So I guess that's like two questions that I had.
Do you want to go, Vic, or do you want me to have a bash? Oh, right, I'm going to have a go at this. So it's not actually a change in healthcare, but there's been a clarification of the existing law on the legal interpretation of a man and a woman, essentially. So I think that's probably what you're alluding to, and it has obviously the connotations or the knock-on effects on, for example, using washrooms and also sports. So it hasn't really got an immediate effect on healthcare. That's my understanding. Obviously, this is a really emerging area in life, let alone in health and social care, isn't it? Because there's things happening. It's a very dynamic situation. So I think we're still coming to terms with what this now means. And there are a lot of conversations going on in the UK about how we operationalise this clarification in law. Anything to add, Vic?
I think you handled that really well. I think the word emerging is definitely the word to use for the situation. And it's interesting because Alison didn't tell you what her profession was. And this is why it's interesting that Alison went first, because Alison's a midwife. So this is what Alison didn't share for you. And for myself, I'm an adult critical care nurse. So I think it's very context dependent as well. And we would be extremely naive to think it won't have an impact on the way that care is delivered, because obviously it will. And I think what we're seeing across all of the nations, and dare I say it, across the world, is the tension that sits between equality, diversity, inclusion, accessibility, social justice. And there is definitely a global tension that is actually taking place across the world at the moment with respect to people's identity, with respect, with people living their lives, and this is a daily occurrence. And I think what's happening in England and the UK at the moment is just another example of the legality that's wrapped around that tension, which people are often very uncomfortable to talk about. It's an uncomfortable space sometimes, but I think if we reflect back on why we're all here this evening, joining you online, or this morning for those of us who it's morning, we're all here because we've all got the shared value of working together across boundaries, whatever those boundaries may be, whether those boundaries are cultural, whether those boundaries are geographical. We are all here because we're passionate about breaking down walls and making sure we give the best care to everybody as a team. So I think if we can harness that ethos and focus on that ethos, and if we place the patient and the person who uses services at the centre, if we retain that focus, then I'm hopeful that people will get the best care and all of the tension that is wrapped around what we do on a daily basis will be, what's the word I'm looking for? Essentially, the care that we give will be holistic. It's that holistic person-centered care. And I'd like to think that looking through that lens, we'll get high quality care irrespective of the tensions that might be wrapped around the edges.
We got another question?
Yeah, this is Josh from Team 19. I had a question for Michael with like disaster care. I was wondering, because you said that you have very good surgeons, but in disaster care, I feel like there'd be more nurses and more nurses involved in emergency response. Would you say that that's a problem as well? Like shortage of like nurses and stuff like that in disaster care?
Yes. Did I hear it? Surgeons? Did you say surgeons?
Problem with surgeons, like they get their degree in English and they leave.
Mhm.
Yeah, and then they leave to another country. But I was wondering if that was a problem with like nurses and other people that are there for the emergency response.
Okay, thank you. I'll try to answer that. I think when it comes to migration, there are more nurses who are migrating rather than medical doctors. But going back to the disaster part, to be part of the disaster team or management team, they call them the disaster management team. Of course, you have not only the healthcare professionals, but also people in the military and people who are trained for disaster response. But in the healthcare team, usually they don't look at the profession. Of course, you need to be a qualified healthcare professional, but you can be a physiotherapist, you could be a nurse, you can be a social worker who would want to focus your work on disaster risk reduction or response management. Did I answer your question?
Yeah, you did.
Okay. Yeah.
Listen, I think it's a good time to transition to our next round.
Yeah.
Well, for the questions that you asked.
Yeah.
Did you- Okay, let's.
Take one more, or you want to move on?
Do we have time, Allison?
We end at 1:45, don't we? So we've got 13 minutes left. I could just get one pearl of wisdom per panel member if you want another question to Dr. Byback.
Maybe. Yep. Okay. Do you want to get them started, Allison?
Yep, sure. So the final question then. So actually we're looking for a pearl of wisdom from our very esteemed, very knowledgeable panel members, please, about can you tell the class what you think is the most important thing in healthcare? I'll go first quickly. So as you know, I'm a midwife by background. For me, it's all about respect. So if different professions respect each other, then healthcare is going to run much more smoothly and the service user is going to get the best possible care because there aren't competing identities, competing egos, if you like, that we're all one team and we're not trying to compete with each other. Over to Vicky Park.
Thank you very much, Alison Power. So as I said, I'm an adult critical care nurse, and I think what's most important in my view for health and social care is holistic, person-centered care. So I'd started to allude to that in my answer before, and ultimately to meet the complex needs of people as humans, they need to be at the center of everything that we do. And when the people are at the center, they become part of the team. And ultimately what that results in is that results in care that not only meets their needs, but means that the people who are involved can work together for what's important to those individuals and in a way that is seamless but also meaningful. I shall hand over to, because I think this is the game we're playing, I am going to hand over to Marion.
Thank you, Vicky. I only can agree with all the words you said, so I'm short. It's a person-centered care, and including the person in the team with all the experiences and value, especially the history of this person. So, and then at the end, it should be holistic. And my profession is a psychologist and a physiotherapist and a nurse. So
Wow, busy. You're just you can just do it all on your own, Marion. You don't need a team. You are the team. Who would you like to go next, Marion?
I will stay in Switzerland, so I take Mike. He also lives
you.
at the moment in Switzerland.
Thank you, Marian. I think the most important value in healthcare now, I think respect. I agree with Alison. Respect with among each other within the healthcare team. Respect with the patients and the family of the clients that we support. And I think access and quality. I think because I always think that you cannot get quality healthcare if you don't first resolve the accessing. So I think access and then quality. Yeah, that's from me.
Pass the baton on, Mike.
Luzanne.
What's your profession, Mike?
Oh, I'm an occupational therapist by profession. Yes. Luzanne.
Thank you, Mike. So I'm a physiotherapist, as I mentioned earlier, but I think for me, I didn't realize that people were going to give philosophical answers. Mine's a bit cornier, but I think I think it's really important that we never lose sight of the person behind the patient. We are so easily caught up in protocol specializations and the systems that we are supposed to be working in. And while those are important, we need to remember the human connection when treating our patients. Understanding where people live, their communities, their struggles, and their strengths that they come into the treatment with. And I think that is why IPE is so important to me, because no matter how skilled we are as professionals, we can't solve this unless you're Marian. You can't solve all the problems on your own as a single profession. And so I think that in that interprofessional team, or an interprofessional approach, with proper communication, shared decision making, and a willingness to learn from each other without that hierarchical system that we are so used to, that the GP is there and the rest of us just fall in line. I'm sorry if there are any GPs in the room. And I think when we break down the silos between the disciplines, it's just so much easier to build teams, and stronger teams, obviously, then resulting in healthier communities and a healthier population. And so I think the pearl of wisdom is just thinking beyond your profession and highlighting the person behind the patient. Thank you. Oh, I feel so privileged to say, John Gilbert.
I'm health services, health policy. That's the focus of my attention. I think the sum result of all of the years that we've had in delivering healthcare publicly, we have yet to decide what is a need and what is a want. And this bedevils healthcare systems everywhere. Wants seem to have raised a very big question mark over the ability to meet the needs of the population with respect to health. And my second point is, I think there are two mighty trains coming down the track that health and social care education and service is going to have to think about very carefully. Number one, AI. Everybody knows AI, but it is a huge, huge issue, and we've got to start addressing it yesterday. And the second is robotics. How are robotics going to change the way in which many subdisciplines across the health and social care sectors practice? So, need and want, robotics and AI. Thank you.
Thank you, John. Do you want to pass the gauntlet?
Can't see who's left.
You've got James and Yan Yap.
Okay, James.
Thanks, John. I agree with all my colleagues on the panel. They give you very wise advice. I'll take a slightly different angle. I'll take the opportunity to, I guess, give the class some advice that I guess I wish I had been given more forthrightly when I was sort of in that position. And that's this idea of I suppose imposter syndrome as a healthcare professional. I had these naive expectations when, oh, by the way, I'm a physiotherapist by background. I trained in the UK before moving to Australia. I had this sort of naive expectation that when I qualified as a physiotherapist, I'd sort of know how to be a physiotherapist, and that absolutely was not the case. And then I thought, oh, if I got a master's degree, then that would fix that problem. And it absolutely didn't. In fact, the more you learn, the more questions you realize there are. And it came pretty late to me, but sort of coming to understand that you always have imposter syndrome and you're never the fully formed health professional. Once I kind of realized that, life became a great deal easier. So it's sort of a little bit cliche, but do, embrace lifelong learning, embrace the complexity of healthcare, and recognize that imposter syndrome will be with you probably for your entire career. And you'll probably just about think you're getting the hang of it. And then you'll get the invitation to get up at 2 o'clock in the morning to sit on an IPE panel with a bunch of global experts, and the whole thing starts again. And so that's just something that you should embrace and really enjoy, because it's such a rewarding career, whichever component of healthcare that you go into. So yeah, I think that just leaves me to hand over to Jan-Jaap.
Thank you. Yeah, I'm a work and organizational psychologist. I'm working with people in education and practice setting, primary care, secondary care, and rehabilitation care. I would say that whatever care and whatever kind of education, we face multifaceted problem domains no single profession can solve. We need each other. So we need diversity, but we also need unity. But diversity is not a problem. As we see in this panel, there's a lot of diversity of expertise, different perspectives. Contrasting perspectives are not contradictory. They are potentially complementary. And when they are, and when you know what they are, and you do not assume, then combining those complementary differences will enable synergy. As a psychologist, unity, interprofessional identity is a second identity, because you can also associate with not only your profession, which is also just as important, because that's a source of motivation. Be different. Be different is extremely important, because that guides you. And we're not just about cognitions, not just about beliefs and orientation on how we should behave, but also, of course, we are people with emotions. Without emotion, there is no motivation. And of course, together, we are better. So true knowledge is knowing what you know and knowing what you don't know.
What a way to end. Thank you, Jan-Jaap. And now back to Dr. Breitbach in the studio.
Way to bring it home, Jan-Jaap. Very nice. Thank you all so very, very much. Thank you, Allison, for moderating expertly. Can we give them all a round of applause for the outstanding job? It is a privilege that you all are colleagues and friends. And class, there's a discussion board that is, your initial post is due tonight at midnight, and then your reply is due tomorrow night at midnight. We will see you on Wednesday. Thank you. Thank you, everyone. Appreciate it very, very much.
Stay safe.